Good morning. Welcome back to Open Med School. The last sessions we have discussed about the GBS in detail. Today I'll be discussing few MCQ based discussion to cover all these aspects. So let us start. I request all of you to have a bit of paper, write down the answer, then only you proceed with the listening of explanation. So first question. Which of the following is the most common form of GBS in Western countries? We have already mentioned that the AIDP constitute more than 52% of case of GBS. Miller-Fisher only a small percentage, less than 4%, and so the correct answer is AIDP. So AIDP is the most common form of GBS. Of this, keep this point in your mind. Go to question number 2. Which of the following antibodies is most commonly associated with Miller-Fisher syndrome? Anti-GM1 is associated with AMAN. Anti-GQ1 is the correct answer. So, Miller-Fisher variant characterized by ophthalmoplegia, ataxia, areflexia. Without much weakness, the antibody is GQ1B antibody. The earliest and most important investigation in a suspected case of GBS is, when you get a case of GBS, the investigations of choice are, one is nerve conduction study, second is CSF. So what is the correct answer? Is the nerve conduction study. CSF usually shows albuminocytological dissociation that will take some more time. After the 1 week or later only, you may get the typical albuminocytological dissociation characterized by increase in protein, but cell count is within normal limits. One exception is the HIV associated GBS, where there can be some cellular response also. Or you take the convoys when there is cellular response, presentation is like GBS, suspect a HIV. Then the next question, albuminocytological dissociation is characterized by, we have already mentioned the answer, elevated protein with a normal WBC count. When the count is more, you should think about HIV associated GBS. Hope this point is clear. Next question, which of the following is not a poor prognostic factor? We have discussed the prognostic factor. Age is a poor prognosis. Rapid progression is a bad prognosis. Early cranial nerve involvement. These patients are prone for developing or need for ventilation. Reflexes returning within 2 days. So what is the correct answer? Reflexes returning within 2 days. So age is a poor prognosis. Rapid progression is poor prognosis. Early cranial nerve is poor prognosis. So we have already discussed these things in detail earlier. Now going to the treatment. The main treatments are, one is plasmapheresis, second is the IVIG. We have discussed the indications, contraindications, etc. The question is, which of the following statement is true regarding treatment of GBS? Steroids are the first line therapy. There is no role for steroids. Both IVIG and plasmapheresis are effective. True. Antibiotics are mainstay. Wrong. Supportive care is rarely needed. Wrong. Supportive care is essential. Now, we already mentioned that the treatment is immunotherapy. What are the indications? Also, we have discussed. Now, we go to the next question. GBS is a typical example of an infection triggering immunological damage to nervous system, especially the peripheral nervous system. So question is, AMAN is most commonly associated with the preceding infection by. The correct answer is Campylobacter jejuni. So infection with Campylobacter jejuni are the most frequent antecedents of AMAN and associated with one antibody, that is the GM1 antibody. So the antibody that is seen is anti-GM1, and the preceding infection is most commonly, and you should remember that this is a axolema. This is the complement mediated attack, membrane attack on the axons, producing damage to axons. It is occurring at the nodes of Ranvier. That is regarding the pathology. Now we go to the next question. Very simple. Which of the following GBS variants is associated with ataxia and ophthalmoplegia? It is the MFS. The triad of findings: ophthalmoplegia, ataxia, and areflexia. There may not be any weakness. So that is the most important variant, and the antibody is GQ1B. Now we go to the next question. Which of the following correctly describes the pathogenesis of ADP? Axonal degeneration by complement attack. No, it is for AMAN. AMAN is characterized by antibody mediated attack and complement mediated. Antibody mediated demyelination by macrophages is partially true. T cell mediated damage to antiretroviral cells, viral infiltration of is wrong. So this is antibody mediated demyelination by macrophage. The T cell and macrophage producing damage to the myelin sheath. That is the pathology. And it occurs predominantly at the roots where the blood-brain barrier is less. So the correct answer is, as mentioned, antibody-mediated demyelination by macrophages. T cells also involved. ADP involves macrophage-mediated demyelination targeting Schwann cell membranes via complement and antibody activation. Next, in GBS, when should ventilatory support be anticipated? The dreaded complication of GBS is respiratory paralysis. So the question is, what are the points by which you go for ventilation? One, of course, you have mentioned for the clinical, that is the respiratory rate more than 30. Think about single breath count less than 15, the use of accessory muscle, so respiration. The most important clinical point is forced vital capacity less than 15 ml per kilogram or 1000 ml. So the correct answer is force. So remember this point: forced vital capacity less than 15 ml per kilogram need intubation. So in GBS, when should ventilator support be anticipated? If the forced vital capacity is less than 15 ml per kilogram or rapid decline in respiratory effort. So rapid progression, bulbar dysfunction, inability to lift the head. So neck muscle weakness is something that you should always check. Bulbar muscles, swallowing, that is difficulty in swallowing, ask the patient to flex the neck and see what's the power. These are indicators that the patient may need respiratory support. Now we go to some case-based questions. So this is a 24-year-old man presents with acute bilateral facial palsy and lower limb reflexia. He had fever and cough 2 weeks ago. What test will give to confirm the GBS? Of course, MRI is not needed. Tensilon is for myasthenia. Troponin is for myocardial infarction. So the CSF analysis showing albuminocytological dissociation. CSF showing albinocytological dissociation supports GBS. But again, remember, this may take some time. Next question. A patient with GBS has rising heart rate, BP fluctuations, and urinary retention. So this indicates autonomic dysfunction. Autonomic instability in GBS may be life-threatening. So typically, the standard teaching is that any pyramidal signs like extensor plantar and or a sensory level on the trunk and significant bladder symptoms always exclude other causes like a transverse myelitis. But again, remember, GBS can present with autonomic dysfunction. We'll go to the next question. A 30-year-old man with weakness and epilepsy has normal sensory nerve conduction study but reduced CMAP amplitude. What is the diagnosis? So in the nerve conduction study, what you are looking for, one is the conduction velocity. The conduction velocity or nerve conduction velocity depends on the myelination. So in any demyelination, because the saltatory conduction, that is by the not because the nodes are angular. So in a AIDP, you get a decrease in the conduction velocity, but the compound muscle action potential is fairly normal. So this is the indicating this may be the normal. So that there will be delay in conduction. So that will produce a delayed compound muscle action potential. So here's a patient has got weakness, areflexia, normal NCS, but reduced CMAP. So the compound muscle action potential depends upon the axons. So this indicates an axonopathy. So the answer will be AMAN. Hope this point is clear. Patients with demyelination, there is conduction velocities. NCS conduction velocity is decreased, and there may be conduction block, about which we have discussed earlier. But in AMAN, it is axonopathy. So the impulses are not reaching the muscle. So you will not get the compound muscle action potential. So AMAN shows normal sensory studies but reduced motor response due to axonal loss. We go to the next case. A patient with ophthalmoplegia, areflexia, and ataxia is diagnosed with. This answer is, of course, very clear. It is Miller-Fisher syndrome. So, to stress once more, Miller-Fisher is a triad of ophthalmoplegia, ataxia, and areflexia. GBS is suspected in a patient who had flu vaccination. What is the most appropriate next step? Answers are observe for 48 hours, start steroids, admit and monitor FVC, start antibiotics. Select your answer. The most important thing for GBS is anticipate things. Admit, observe. The forced vital capacity, bulbar symptoms. So try the patient depending upon the FVC. FVC less than 15 ml, single breath count less than 15, evidence of respiratory muscle involvement are indications for close monitoring and anticipation for intubation. A 15-year-old child with GBS recovers completely within 3 weeks. What variant is most likely? Pierre said the man has got a bad prognosis. CADP is wrong answer because it is a long condition. AMSAN has got again prognosis, so it's more likely ADP. ADP typically has a good prognosis, especially in children. So that's the point to remember. Okay, go to the next question. A diabetic patient develops rapid ascending paralysis and weakness. How to differentiate GBS from polyneuropathy. CT brain is not useful, MRI is not useful, pressure is not useful. So two studies are, one is the nerve conduction studies and CSF. We have already CSF showing albinocytologic dissociation. Here it is the conduction block or prolonged latency. NCV shows conduction velocity is decreased. Now, few questions on variants of GBS. AMAN is different from AIDP in that reflexes are always preserved, autonomic symptoms are more, antibodies at. So correct answer is antibodies attack axolema. Antibodies attack. AMAN involves immune attack on motor axon membranes at nodes of Ranvier. So AMAN is as mentioned. So this is the nerve, and think that this is the myelin sheath. ADP produces demyelination. Axons are intact. Whereas AMAN produces damage to axons. Okay. So next question, which variant has both motor and sensory axon involvement? Very simple question. It is AMSAN. AMSAN is a severe axonal form involving motor and sensory nerves. So AMSAN has got an axonopathy with motor and sensory involvement. Most GBS variants show which antibody? We have said about the antibodies. Answer is anti-GM1 antibody. So the most common variant is AMAN. So in AMAN the antibody is anti-GM1. Hope this question and answer is clear to you. Which GBS variant is most likely to require prolonged mechanical ventilation? Answer again we have discussed AMAN because ADP has got a better prognosis. Miller-Fish also good prognosis. Pan dysautonomia usually doesn't require a ventilator support. ADP has got a better prognosis, and the NCV shows evidence of axonal damage. It has got a bad prognosis. Which variant of GBS is associated with isolated bulbar weakness? We have mentioned that GBS is an ascending paralysis usually typically. But there is one variant, the pharyngocervicobrachial. This is associated with isolated bulbar weakness. Patient can start with the bulbar symptoms. That is why you already mentioned that you should check the neck muscle power in all cases of GBS. Then that will be finally 4 assertion reason questions. Assertion. IVIG is preferred over steroids in GBS. Corticosteroids worsen outcomes in GBS. You know the types of responses. Write down your answer. Steroids have been shown to be ineffective and harmful in GBS. So the answer is A. Assertion. CSF analysis is normal in early GBS. Reason albinocytological dissociation may appear after 1 week. Assertion and reason are correct. Both are true and reason explains the assertion. CSF analysis normal in early GBS. Albinocytological dissociation may appear after 1 week. GBS does not involve CNS. The immune attack is limited to lower motor neurons and peripheral nerves. Again, GBS is a peripheral nervous system disease unlike MS. So this is an important thing to remember here. There is a immunological attacks on the peripheral nervous system mainly, whereas in multiple sclerosis it is the central nervous system. The last question. MFS can occur without limb weakness. The assertion MFS targets cranial nerves and proprioceptive pathways A and so the is correct. Limb weakness is absent in 80 to 90% of MFS. So today we have covered the core topic of core areas of GBS. Hope it was useful.